So we are demonstrating the first step of histopathology, and that is tissue processing. Before any kind of histopathological staining, we have to do an embedding of the tissue mm, into the paraffin block, and after that we have to cut the sections into 4 micrometer to 5 micrometer thin slices, and that slices when mounted onto the glass slides can be further used for immunohistochemistry, histopathological stainings, and many other purposes. So here the first step, we have a vacuum embedding chamber here in which we put the tissues and let the paraffin infuse into the tissue properly. After that we put it in blocks. The blocks are kept here within brackets, and after that the final result is that this is a paraffin block in which the tissue is embedded inside the paraffin. So what paraffin wax does, it provides a structural support and makes the tissue rigid enough to be cut into small sections. So right now here we have a microtome. This microtome has the block already attached onto it. There is a blade which is used for cutting this. Here is a knob which can select the thickness of the slice. It can range from 2 micrometers to 10 micrometers based on our requirements, and this is a rotary microtome. That means this rotational movement will translate to a lateral movement of the block in the forward direction. So the other than the microtome, what we also need is a water bath. This water bath is kept at 60 degrees Celsius, so that after we cut the sections as ribbons, we put it on the water bath so that they spread out evenly. The reason we need them to spread out evenly is so that the tissue does not get wrinkled in the process of mounting it on the glass slide. Prior to mounting, we have to coat the glass slides with an electropositive charge. Usually we use ovalbumin. For immunohistochemical techniques we use polyl lysine. Right now we have ovalbumin coated glass slides, and these needs to be kept ready. So the process of making thin sections is like so. We take the uh, uh, block and rotate the sections very slowly. We let some of the sections go by. And we put the ribbon in the water bath for the wax to completely spread out. We take the ovalbumin coated slide and gently place it below the floating wax and swiftly put the paraffin ribbons on the glass slide like so. Now this is ready for further processing. After this we have to dry it for a certain amount of time, after which we can remove the paraffin using xylene, and then we have to put it in alcohol to remove all the xylene, and after that for staining, which are mostly hydrophilic stains, we have to put it in graded dilutions of water. So from 90% ethanol to 70% ethanol to 50% ethanol, then to water. We keep it in the water, hydrate the samples completely, and add the staining of interest. So the most widely used stain is the HE stain, the hematoxylin and eosin stain, where hematoxylin stains the nucleus and eosin stains the cytoplasm. And so after we sequentially do both, add both the staining we have to go back into dehydrating the samples. So we have to do the graded dehydration again, which is 50% alcohol, 70% alcohol, 90% alcohol to 100% alcohol. Once the samples is completely dehydrated, we have to air dry it for some time. We have to clear it in xylene and then mount it using a mountant like DPX and put a cover slip on it. Now the slides are permanent slides which is completely stained and ready for visualization in the bright field or fluorescent microscopes. That's it.
And I work in histopathology. My area of interest is gynae soft tissue. So what is pathology is the study of disease, right? And it's basically divided into two things, right? One is histopathology, one is hematology. Hematology is study of blood, bone marrow, and everything else is histopathology. That is all solid tissues of the body, they are studied under histopathology, right? So when a patient presents with certain symptoms, right, loss of weight, anemia, some pain in some part of the body, we order a set of area specific radiological investigations. All right, and if we see any space occupying lesion within that area, right, what we do is a biopsy. So in histopathology there are two kinds of specimens majorly. One is a biopsy specimen, other is a resection specimen. For a biopsy specimen, the intent of doing a biopsy, you stick a needle into the body, right, and take out a small piece of tissue. So the intent of doing a biopsy is, first of all, what do you think? It's a diagnosis of the disease, right? We have to diagnose the tumor, then we have to grade the tumor and type the tumor. So, but what else can we get from a biopsy? We can get additional layers of information. We can get the protein level alterations and any gene mutations. So on this same tissue that we have taken out, we can see protein alterations and we can see gene alterations or mutations. So if we have a breast lump in a patient, so the patient comes in, gets a mammogram, and we have a breast lump, we'll take out a bit of the tissue and I'll see it under the microscope and say it's a, if there's a tumor, I'll say it's a breast carcinoma. I will grade it and say it's an invasive breast carcinoma grade 2 or grade 3 depending on the histological features, right? So what more can I get from that tissue which will help the patient? So on that tissue I can see the protein expression of certain proteins which are part of that tumor cells, and I can assess their level of their presence in the either the nucleus or the cytoplasm or the cell membrane, right? And expression of proteins has a predictive and a prognostic impact on the patient. If certain proteins are expressed in tumor cells at a high level, we can give certain drugs which target that protein. For example, in all breast carcinomas, we do an ER/PR assessment, right? So assessment of expression of estrogen receptor and progesterone receptor, right? So if they are highly expressed, I can give certain anti-estrogenic drugs, right, and which will inhibit the growth of that tumor. So I have to devise a test which will accurately tell me the level of ER and PR expression, and that test is called a immunohistochemistry. So I am assessing the protein expression on the slide, right? The second thing I can do is a HER2 expression, human epidermal growth factor expression, and there is a targeted drug called trastuzumab available, right, which will, in cases of HER2 positive breast carcinomas, which can be given, right? So these drugs have a very strong prognostic impact on patients, right? And for certain tumors like lung carcinomas, in a biopsy I will diagnose the tumor, I will grade it, I'll tell about the morphology, I will see protein expression of ALK, right, and I will send it for mutation testing also routinely for all lung carcinomas as a matter of practice today, right? All these tests are done routinely, they are recommended guidelines, right? So ALK expression and EGFR mutation and ROS1 testing. So ALK expression can be done by immunohistochemistry, ROS1 rearrangement by FISH, and EGFR mutation detection by PCR. So one is a protein level alteration, the other two are gene level alterations. Right? Rossmann rearrangement is a gene level alteration, EGFR is a point mutation usually, or an insertion deletion. And the presence of these mutations, right, they correlate with the therapeutic response to a certain class of drugs. So if my tests are accurate and standardized, right, I will have good information which is of benefit to that patient and which can drastically improve survival for years for that patient. Okay. Now this is for a biopsy specimen. Now the second kind of specimen we have is a resection specimen, right? So which is usually done either with a curative intent to take out the tumor from the body or with a palliative intent, that is you take out to improve the quality of life for a patient. Okay, for curative intent tumors taken out, resected from the body, we have to stage the tumor. Staging is T&M staging. It is a reflection of the size of the tumor, how much the tumor has spread across through that organ, or it has gone across the anatomical boundaries. Alright, so these staging guidelines are different for different sites of tumors. Okay. So T is tumor staging. It is a reflection of the tumor size and whether tumor has, like for a breast carcinoma, it is dependent on like more than 2 centimeters, less than 2 centimeter, more than 5 centimeter, or whether it has spread, ulcerated the skin, gone into the chest wall. And similarly for colon, how much does it spread into the wall, whether it has penetrated the serosa. So that data is captured via T staging. The second thing is a nodal assessment. So along with the resection specimen, lymph nodes are taken out and we give a count how many nodes are involved. So based on that we stage it N1, N2, N3 and so on and so forth. The third parameter which is important is a M, that is a distant metastasis, which is usually evaluated radiologically, like a colon carcinoma going into lung and like that. So CT thorax is routinely done for cancer patients today. Right? And I'll show you the biopsy of a breast cancer, and I'll show you the IHC expression, how we evaluate. Right. So this is a breast carcinoma, and these are all tumor cells here, right? And you can see they're infiltrating the normal fat of the tissue and eliciting a stromal reaction, right? So on this slide, what I can do is I can grade this tumor, grade 1, grade 2, grade 3, whatever it is, based on the tubule formation, nuclear features, pleomorphism, and the mitotic count. All right. Then what more can I do with this tissue? I can assess the expression of ER, that is estrogen receptor, using immunohistochemistry. So you can see in this tumor there is a nuclear staining for estrogen receptor. It is strong and it's there in more than 90% cells. So I will call it ER positive, Aldrich score 8 by 8. Right? And there is a scoring system for ER and PR both. And similarly we do a HER2/neu testing. So this HER2/neu is a membrane stain, and we can see there are many tumor cells here, but there is no membrane staining. So this is negative for HER2/neu. Alright. And similarly we can do a Ki67 index, which is a reflection of the tumor grade. Right? And here we can see that this is a high grade tumor. So Ki67 index is at least present a little bit, maybe less than half of the cells. So around, I will say it's like 40 to 45 or 45 to 50%. So it doesn't matter as much whether it is 40% or 50%, but when it is close to 10% it may matter, because if a tumor is Ki67 value is a low grade, low stage tumor with a Ki67 index of let's say less than 10%, the patient might not get chemotherapy. And if it is more than 15%, the patient will get chemotherapy. So in certain situations, accurate assessment of Ki67 is important. And this is a function of, which is a proportion scoring. how many percentage of cells are expressing. So I have to examine this in the entire core and give a one value. So if there are 3 cores here, I have to see across all cores and give one value. So here I think if we use some digitalize this slide and try and isolate the tumor cells and see how many tumor cells are actually expressing Ki67, that scoring can be more accurate because you will be able to sample a larger number of cases, larger number of cells.
So now we are having a demonstration of the fluorescence microscopy, and here is an inverted microscope in front of us, and this can also image in fluorescence mode in reflection. So the light source comes from below the sample, goes through the objective, falls on the sample, and the emission is captured, and we get the fluorescence data. So here we have the software to visualize. So now we are visualizing a sample of fluorescence which has an excitation in UV emission in blue, excitation in blue, emission in green, excitation in green, and emission in red. So it's a 3-channel imaging system. So while this is getting loaded, the few objectives that we have here, we are going to currently observe it in 20x objective apochromatic lens with a numerical aperture of 0.8 nano 0.8, and so as you can see there is an array of objectives we can choose from. We have chosen a 20x objective, and we'll go into multi-dimensional acquisition and we'll set the color. So we can excite in blue, we can get emission in blue, green and red. So we'll go to the individual color channels to see the fluorescence. So for example, this is the blue fluorescence of one of the samples, of the sample that is under the microscope. So we have to change the focus. I think this is quite well focused. Okay. As you can see, the surrounding regions are not as focused. This is because the sample is thicker for the objective magnification we are using right now. We can see the green color fluorescence. We can change the exposure time a little bit to get the maximum contrast, to get the best signal to noise ratio. And this is again the red channel. So this is the red fluorescence. Again we have to reduce the noise, so we have to control the exposure accordingly. So this is somewhat okay. Okay. Second, we can also change the stacks. So let's say we want to capture 7 stacks, and with a space of 1 micrometer, so we can capture 3D volume afterwards. So we have to center at the focus that we have currently acquired. We can also change time. If you are doing time-lapse imaging for dynamic systems, we can put the speed of imaging, the interval for the duration of time that we want to image. We can do all of that. So let's start the experiment, see what happens. So here you can see it is capturing the first channel, which is the blue channel, and it is taking the stacks 3, 4, 5. So it will take 7 stacks for each color channels, and then it will go to the other channels afterwards. So as you can see, the color is changing. That means they are changing the emission and excitation gates. So all the colors are here, all the channels are merged together in this. So if we want to see individual channels, so this is the blue channel, this is the green channel, and this is the red channel image. So for example, we want to see only the, let's say, green channel image for example, and we want to see uh, all the depths. So we can play it, the video, as you can see. So as it is taking different depths, so different areas of the samples are getting in focus. Okay, we can go to the 3D viewer. You can see, so a stack has been acquired for a region of the tissue. We can obviously zoom in to see more features. The cells are present here, and we can do further analysis on that. We can go to the 3D viewer.